Thank you, Martin. Also, thank you, Simona, for giving me or us the opportunity to share, so as one of the MSU groups, our experiences here in this webinar. So these are my disclosures. So you can see my financial disclosures in the table. Probably more important is that I'm the coordinator of the Berlin MSU program. I'm also the current president of PRESTO, which is the pre-hospital stroke organization. So before we come to the challenges and the opportunities, I would like to talk about the effects of thrombolysis in different time windows. You all know about it, but I just want to make it visible. So I would like to refer to the placebo arm of the NINS trial, and even with placebo, 26% of the patients actually achieved a favorable outcome, so without disability at 3 months. If we treat patients in the late time window, so between 3 and 4.5 hours, according to the number need to treat given in the pooled analysis by Ken Lees and colleagues, we can save additional 7 patients from disability at 3 months. If we treat patients much earlier, so between 1 and 1.5 hours, we can save additional 15 patients from disability, adding up to 22 patients. And the question remained actually, because in the randomized controlled trials, eventually no patient was treated within 60 minutes. What would happen if we can treat patients within 60 minutes? And we have got data from the Berlin registry-based study, and if we extrapolate these results, actually we can save additional 20 patients, so adding up to 42 patients from disability. And so this actually is close to a number needed to treat of 2. I think it's important when we talk about treatment within 60 minutes, which is also expressed as the golden hour, that we are not the first ones who talk about golden hour. Actually, traumatologists have taken this term for several decades. And when you read in Wikipedia, so the term was obviously originally invented by the French army during World War I. And very interestingly, a person we all know, but actually for her scientific merits, who was not a physician, Marie Curie, at the beginning of World War I, actually she put X-ray equipment on a Renault truck, and she herself and her daughter actually went to the front line, scanned thousands of patients, wounded soldiers, and trained technicians. So at the end of World War I, more than 20 of these, they were called Petit Curie, were in operation at the front line of the French army. So back to our mobile stroke units. As Silke already mentioned, Klaus Fassbender was the first one who described the concept in 2003, and also his group was the first one who invented or who implemented an MSU in Hamburg in Germany. A few years later, we had the opportunity to start an MSU here in Berlin. And so in 2012 and 14, the first cluster randomized trials were actually presented with time savings of 33 and 25 minutes. In 2015, the first MSU were implemented in the United States. And in 2016, it was the first already mentioned registry-based study that suggested improved outcome in patients if they were thrombolyzed on an MSU. And last year, actually, we had the 2 large intervention trials, also an additional one from Norway, showing improved outcome at 3 months. So when we implement an MSU service, I think we have 2 central aims. And one is to treat ischemic stroke patients as fast as possible. And the second is to treat as many eligible patients as possible. And the first one is actually aiming for better effectiveness. The second one is aiming for better efficiency. So there are always some basic questions. They are, so what is the right or the best setting for MSUs? What would be the optimal size of an MSU, equipment and staffing? So how can we ensure optimal dispatch quality? How can this be reimbursed? And finally, how can the processes be further optimized? So I think when I start with challenges, I would like to emphasize that we usually are neurologists or stroke physicians, and we are hospital-based physicians. And this means that we are usually not very familiar with pre-hospital emergency medicine. So we need advice and we need close communication with EMS professionals. They may actually fear that if they start a specialized ambulance for stroke patients, every discipline will come and say, okay, we need our own ambulance. We need to liaise with stakeholders. I think first we need to liaise with patients or advocacy organizations. Usually they are very interested in such an approach. Then we need to, of course, we need to approach public representatives, public politicians, and also health insurers who finally may then pay for the service. And of course, we need to liaise with professional organizations. I think our neurological societies had been rather skeptical at the beginning, but I think that has changed. And then I think we need to be very close to our crucial central partners, that is the dispatch center, then the EMS providers, and finally other hospitals in our catchment area, because they may be worried to be bypassed. So as we in the MSU see the patients first, we of course can decide where the patient goes, and that is a frequently expressed worry that they get bypassed. And then it comes to the setting, and many people think so an MSU service would probably be best placed in a very rural area because of the long distances. I would like to share my personal opinion and take so our geographical setting in the northeast of Germany. We are in close collaboration with a university hospital in Greifswald here in the northeast, very northeastern part of Germany. In order to cover 1 million people in this area, you would get very long distances. And if a patient in the western or southern part of the state of Mecklenburg-Vorpommern needs to be treated with an MSU, you would probably need around 2 hours to get to the patient, which makes it very difficult to save time. In contrast, in the metropolitan area of Berlin, with more than 5 million people, it's very easy to keep the MSUs busy and to see many stroke patients. Although, of course, the distances are very much shorter, but the most time we save is actually not distance related, but actually by avoiding handovers. I think there are two ways of dispatch. One is the standard way, which means simultaneous dispatch of a normal ambulance and the MSU. Both meet at scene, which means that actually usually the normal ambulance arrives first and the MSU second. And then there is the alternative, what we call the meet and greet approach, which is, for example, practiced in Edmonton in Canada. Again, they use simultaneous dispatch with a first responder ambulance, but then the normal ambulance arrives much earlier. They take the patient and ship it towards the central area with the actually MSU already driving into its direction. Then they meet en route, take the patient to the MSU and examine the patient immediately. And as an alternative, the MSU can also be activated by the first responder ambulance. When it comes to the MSU architecture and equipment and staffing, I think there are always some common elements. We all need a CT scanner. We all need a mini lab. Most of the MSUs are actually connected via teleradiology to radiologists who then provide the reading. And as Silke already mentioned, we have specialized teams on board. And then there are very individual solutions that depend very much on the local settings. For example, if you are based in an old European city with narrow streets, you may prefer actually a smaller ambulance. On the other hand, if you want to do a lot of research on an ambulance, you may need more space. For example, our MSU actually has a radiation shielded chamber, as you see in the front of the ambulance, and all the lab equipment is placed here in this area as well. So this makes it very easy for us to do research in this setting. It also depends on the healthcare setting. There are many countries with physicians working in the pre-hospital area, but also countries without. And in these countries, actually, telemedicine can do a great job by replacing the stroke physician on the MSU. And then there are some local preferences. For example, in Melbourne, the entire MSU service actually is based on Mercedes Sprinter ambulances, and they therefore prefer such an ambulance. And as Silke actually showed you, there are so different variants. Choose your ambulance. If you want to use a full body scanner, you can, for example, you can use the Memphis ambulance, which is really rather big. As I already told you, dispatch is very important and probably actually maybe the most important issue. And we have just finalized a survey in the Bresto group that actually showed us that less than 10% of the dispatches finally result in intravenous thrombolysis. And there are many different dispatch algorithms in place in the dispatch centers. So some actually don't even have an algorithm. They completely rely on experienced dispatches. Some have locally developed algorithms, and some use commercial ones like the medical priority dispatch system. But one thing is actually very clear, that dispatchers need training, and not only before you launch your MSU service, but also on a regular basis. One aim is to raise the awareness of the dispatchers for less frequent stroke symptoms. So this would increase the sensitivity. But at the same time, actually, they should avoid inappropriate dispatches, for example, by avoiding dispatches for patients with time already more than 4 hours from onset to dispatch, or patients with non-stroke symptoms. And you should be aware that, as everywhere, I think priorities are changing also in dispatch centers, so we need to raise this awareness again. Okay, here we are again. We have already prepared that in the Bresto group. Good, then we come to reimbursement. That, of course, again, depends on the healthcare system. Most of the current MSU services are still based on research funding or charity funding. In Berlin, we are getting reimbursement on a provisional regular care basis since 2016. So the final decision whether this goes to regular care has not been made. But there are negotiations on both sides of the Atlantic, and these negotiations are based, of course, on the individual study results, on the meta-analysis, which will be available over the next days, and now also, of course, on the ESO guideline, the first guideline on MSU, and also on cost effectiveness studies. So we have presented our incremental costs for per quality at the ESOC with 41,000 euros, and the results of the health economics analysis of the best MSU trials are also awaited in the near future. Sorry. Okay, so in order to get the processes optimized even further, I think we need appropriate documentation. In Bresto, we have now prepared a minimal data set. Then we always should be aware that MSU is a team approach. So each of the team members actually needs training, and we have seen learning curves, and usually it takes a few weeks or even months to become very quick. Then we have the need of ongoing quality management, and I think the key performance indicators can be time metrics, stroke mimic rates, and symptomatic intracranial hemorrhages. We need to collaborate with the EMS providers in order to clarify how to handle cancellations, whether en route dispatch should be allowed or not, and how actually the normal ambulance teams should prepare the patients until the MSU arrives. And we need coordination with the hospitals. So in case a patient has already got a CTA on the MSU showing a large vessel occlusion, I think the patient should not go to the emergency department, but the patient should actually go directly to the angio suite in order to get immediate treatment. Good. And finally, I think there are huge opportunities straight ahead. The faster workup we can provide in MSU should also be beneficial for intracranial or intracerebral hemorrhage patient. We can start earlier blood pressure management. We can start earlier reversal of anticoagulation. We can use the MSU as a research platform. For example, on both sides of the Atlantic, we participate in the fastest trial examining activated factor 7. I think we get better understanding of the pathophysiology in hyperacute stroke, and therefore many of the groups are working with biomarkers. We can examine new therapeutic approaches like neuroprotective treatments or zonal thrombolysis during the transport. And as Silke already mentioned, we are developing alternative diagnostics based, for example, on ultrasound, microwave, telemedicine technologies. And in my last slide, I just want to again mention that MSU is a team approach, so we need to closely collaborate with many people. And I would actually thank our group here and the many others in Presto, and also Silke, who shared her experiences before, so in the preparation of this talk. Thank you.